Good morning. It's a pleasure to be with you. I'm Ira Byock. Like so many of my esteemed panel and so many of you, I've been doing this work since the Dead Sea was merely ill. And from that perspective, I have to say that I fully believe that a true public health crisis persists in the way seriously ill Americans are cared for and experience the last months of life. We are losing, as a nation, we're losing the race against the twin demographic tidal waves of aging and chronic illness. Despite good faith efforts and lots of centers of excellence and demonstrations of excellence, we have made only modest and incremental change. As William Gibson, the famous futurist and science fiction writer, once said, the future is here, it's just not very evenly distributed. We have demonstrated, though, that much better care is both feasible and affordable. Let me suggest that, as my colleagues are sort of teeing it up, that the time for incremental change has passed. We no longer have that luxury. Creative disruption is needed. One such creative disruption I would submit conceptually is that a frame shift is needed. We keep defining aging and illness and dying as being fundamentally medical. They aren't. They're only partly medical. Aging, illness, and dying are fundamentally personal, intensely so, for individuals and families. We keep defining them as medical. It's like looking for the keys under the lamppost, because that's the only way you get things paid for. Well, the other way you get things paid for in America is by defining things as a criminal justice problem. So we can make aging and illness and dying illegal, and there'd be a payment stream for it, but instead we fall back to the medical. But that's not right. Let me move very quickly to what we can do. Number one, it's past time to reform the hospice Medicare benefit. We keep hearing how hospice is great, but you can't get it. But that's not a God-given limitation. You can get it in Canada and the United Kingdom and in Australia. Why can't you get it here? The assumption is that it would be too expensive, but we now know from lots of years of data that that's wrong, that that's turned upside down. We're actually paying more for worse care. Hospice and palliative care must be available to all across settings. But as important as they are, that's not sufficient. The presence of a palliative care service within a health system or a hospice service within a health system does not substitute for measurable system-wide quality improvement in patient and family-centered dimensions of care. Hospice and palliative care are instrumental, and yet they are not the thing itself. They are not the ultimate goal. That distinction must be made clearly if we're going to regain trust. Because let's face it, the variation of quality makes it hard to say in a blanket way, well, if you get to a palliative care service, if you get to a hospice service, things will be fine. I know, anecdotally at least, and through some of the data that Joan just mentioned, that that's not true. Alternative models, such as PACE and the Eden and Greenhouse models in long-term care, certainly deserve our support. We must standardize definitions of palliative care. Many hospital and health systems now claim to have palliative care services, and it's disingenuous. It's simply not true. As Sean was saying, the Joint Commission and various other accreditation and certification bodies need to standardize measures. So does CMS. We must standardize meaningful measures and make outcomes available so citizen consumers as well as clinicians can define where a good hospital and health system is and where one isn't. We must mandate meaningful, major curriculum change in medical education and graduate training. Again, many of our leading medical schools are disingenuous in claiming that they teach the fundamentals of palliative care when those of us who meet these residents know that they simply do not. The residents know they do not. As a rough guideline for undergraduate medical curriculum time devoted to hospice and palliative care, I would say look at parity with the time and content currently devoted to prenatal care, labor and delivery, and neonatal care. There is time in the medical curriculum. The deans are being disingenuous in saying that there's not time, since we know that many medical schools are going to 3-year curriculums. There must be time now in that 4-year curriculum. We must demand changes in licensure for physicians to practice medicine. Part 3 national boards and at the state level, the board medical examiners have a responsibility to the public to ensure that physicians have adequate attitudes, knowledge, and skills to practice safely on seriously ill and dying patients. I can detail some of the basics, but I don't have the time. It's in a paper that is available to you in a PDF. We must reinvigorate aging services and area agencies on aging. These are threadbare, usually struggling in each community, but they are in each community, and they can be their missions can be expanded, and true care planning and coordination that is person-centered, not even patient-centered, can reside there as well. We must begin to think community, not just clinically. Much more effort needs to be devoted towards supporting family caregivers and educating them in their role, but also in self-care in so many ways. As I close, let me give two other provocative suggestions. First, we simply must stop paying for bad care. And I define bad care as treatments for which there is little or no evidence of efficacy, but carries significant patient burden, or there's significant evidence of deleterious effects, or for treatments that may be effective and we would want to use in some circumstances, treatments that are applied without any evidence of shared decision-making and planning that allows us to know that they're consistent with the values, preferences, and priorities of the persons for which they are being applied. That's simply bad care. The Choose Wisely initiative and some of the published guidelines of places like of institutions like ASCO can provide examples. One of my favorites that I've been sort of writing about for years has been multiple fraction radiotherapy for patients with uncomplicated bone mets with advanced disease. We know that a single fraction works as well. Why do we keep paying for 15 fractions? You know, they don't pay for it in Canada, the United Kingdom. Why here? Chemotherapy within 2 weeks of death for something like non-small cell lung carcinoma. The default should be simply not to pay for it. ASCO thinks it's bad care. Now, I'm not saying to not pay for any of it. The default should be that it has to be reviewed on a case-by-case basis. Aortic valve replacement for patients with moderate to severe dementia in whom there is no evidence of shared decision-making. This is not rationing. I want to be very clear, and these guidelines could be put in place without the scare tactics being brought against it of rationing. We're simply wanting advanced care planning and shared decision-making to know that we are giving the best care possible to each person. Finally, citizens and consumers need a voice. Heightened social cultural awareness and citizen consumer movements are necessary to hold clinicians and health systems accountable for real quality. Let me ask, in America today, who speaks for seriously ill and dying Americans? It used to be hospice and palliative care. I would submit it is no longer us. They need a voice. Without a voice, we will not get to the goals that we can achieve. Government can play a role in giving the public information it needs, including explaining to patients and families what to expect, what to ask for or demand, and when and how to complain when they're not getting it. This is especially important for vulnerable populations at risk of unmet basic needs on one hand and over-treatment on another. Lastly, we really need to refocus on health and well-being through the end of life. That's what we boomers want. That phrase, dying well, doesn't refer so much as an adverb to the process, but as an adjective to the person. It is possible within the human condition to have a sense of well-being through the end of life. I can think of no higher health goal for myself as a physician treating patients, or for our nation. Thank you.